Hello, everyone. Thanks for joining. I think we're going to go ahead and get started. I'm Dr. James Cross. I'm a research fellow at LSHTM working on NEST 360, and I'm the co-lead for the NEST 360 UNICEF Newborn Toolkit IPC HSBB, which we're going to be talking about today. Welcome to our third Infection Prevention, Detection and Care HSBB Implementation Learning Seminar. This seminar is part of a series looking to encourage this collaborative learning for the advancement of small and sick newborn care. As previously mentioned, these seminars are based around different health system building blocks, and we encourage you to have a look at our toolkit website and sign up to our toolkit newsletter. Links can be shown, are shown here, and I think also being posted in the chat as well. Next slide, brilliant. So today we're going to be hearing from some great researchers and clinicians who will take us through diagnostics for neonatal sepsis, current practice, and promising innovations. I hope that you enjoyed today's sessions. Mita will be introducing each of the wonderful speakers that we have that have offered to speak to us today. If you have any questions, comments, feedback, please feel free to ask within the Q&A session at the end, but also feel free to post in the chat, and we'll try and keep up and reply to questions and comments as we go through. And I just really hope that you enjoyed this wonderful seminar that we've got planned today. And yeah, thanks very much. Over to the next speaker.
Hi, my name is Mita. I assist organising the Newborn Toolkit seminar series. On today's agenda, we start off with Dr. Martha Franklin, who will be discussing overview of current neonatal sepsis diagnostics and their limitations, highlighting pathways, biomarkers and bugs. Then we'll be followed by Dr. Niescierenko, who will be discussing biomarker use in LMICs. Then we'll be talking to Dr. Cecilia Ferreyra from FINDx, who will be discussing current landscape for neonatal sepsis diagnostics. And finally, a Q&A and discussion with panelists from Professor Kara Palamountain from Northwestern University. We hope you enjoy our agenda. Passing over to you, Dr. Martha Franklin.
Thank you, Mita, for the welcoming remarks. And thank you for everyone who has managed to join today's presentation. So I'll be talking about just my experience basically on the neonatal sepsis, and I'll be based on the diagnosis and the challenges, what we face in our day-to-day practices, and we'll mention a little bit the current bugs that we are seeing and what is the way forward that are working in Africa. Next slide, please. So that's the title of my presentation. Next slide. So in summary, those are the 4 areas that we are going to look at it. The overview of sepsis, what are the causes of sepsis that we are seeing, the resistance pattern that we are seeing, and as I've said, I'll conclude on what I propose as a way forward as far as the neonatal sepsis is concerned. Next slide. So if we look on the causes of neonatal mortality globally and Africa in general, there are 3 major causes. One is birth asphyxia, neonatal sepsis, and prematurity and related complication. And neonatal sepsis can be on the 3rd one. And much as if you look at it on the economic burden, the way it poses in this part of the world, it is estimated around 10 to 470 billions are used, and this could be saved if only we are able to do correct investigations and treatment. The number might feel high, but just try to imagine a newborn baby that is admitted in your unit, or rather in my unit for that matter, and then the baby is came is not septic, is probably, let's say it was born prematurely, and then it got infection. Instead of going home within few days, it spends a couple of days in a hospital. Let us try to estimate the cost that this one baby would incur for being in a hospital to care for it, the cost of investigations, the cost of medication, the cost of the caretaker, the cost the family has to incur because now the baby is sick. And this has been scientifically calculated by our colleague who assessed the burden of neonatal sepsis. And they are looking in terms of like, if a baby is born, can either be admitted in the neonatal unit, might not have sepsis, but it might get sepsis. And that is why we are seeing it as a third cause of neonatal mortality. And then if it gets a sepsis, it will die. This baby will not die immediately. And if it survives, it might have some acute complication. Some of them, they'll just survive without any complications. But there are two types of complications that you can see. You might get a post-infectious hydrocephalus, and once you get these ones, this baby will be in your facility for quite some time, including they might die because of that one. Or if they survive the hydrocephalus itself, they might have a neurological impairment. And for those who have a neurological impairment, they might end up with cerebral palsy, and this further causes an increment on their expenditure to a healthcare facility. Back in the days when my grandmother was still around, women would give birth to a number of babies because they don't know which one would survive. And we are sort of seeing that one at the moment because, I don't know, maybe in the Western world, somebody will be excited that is pregnant and will be almost certain that if a baby is born, they'll go home with it. But in Africa, the situation is not like so. People hide about their pregnancy. Women are scared to celebrate it because they don't know. If you go to deliver, you go in a delivery room, you don't know if you come out alive. If you come out alive, will you be able to hold your baby? And that is why, for example, you see most of our moms, for example, they probably don't buy the baby's clothes. They name a child until when it is born. And this is because of the fear of losing a baby. And studies have shown maybe sometimes we have a high fertility rate, not because of choice, but for the fear of losing these newborn babies. And the challenge we are seeing as far as neonatal sepsis is concerned, one is the diagnosis. Sometimes we fail to best diagnose neonatal sepsis. A baby is having a multi-10 will be labeled with a congenital pneumonia. A baby with sepsis will not be given the right diagnosis. The investigations are scarce and limited. Most of the facilities that can thoroughly investigate these babies and come to a point of understanding what bug the baby is having are tertiary facilities. And we only know tertiary facilities are only seeing a tip of an iceberg of babies that are admitted. The lower facilities do not really do much of the investigation. I remember when I was in a medical school, sometimes we used to think if you have a newborn baby that is sick, your ampiclox and gentamicin will do the magic. And then treatment, because you cannot investigate and confirm, there's a lot of empirical treatment. And the challenge comes, when do you stop treatment? Because you've started empirically, then you're in a dilemma, should you stop after 48 hours, 72 hours, 5 days, 7 days, especially when the baby is on a borderline clinical presentations, because you don't know, am I dealing with sepsis or it's something else? And those are the main three challenges as far as management of neonatal sepsis is concerned. Next slide, please. So what is the actual prevalence? It is estimated maybe the actual prevalence is probably higher. Our sister in Nigeria did a systematic review and meta-analysis just to see the burden of neonatal sepsis. And if you look on the map on the right side, the color code depict the countries with a lot of, more than 10 studies on neonatal. You can see Nigeria, South Africa, and Kenya have more than 10 studies that have been published on neonatal sepsis. And this was looking on a past decade between 2008 and 2018. And then we have countries like maybe Tanzania, Ghana, and Ethiopia that are coming up. But we don't have a lot of data in a lot of areas. It could be because we don't do research or we don't publish for a number of reasons. And then the data that is available is only hospital-based. Most of these are single site. And then we have limited laboratory facilities. Most of the time you find when this type of research are being done, a baby is being scrutinized to number of tests as per protocol because it's a research activity. But after the study is gone, sometimes those tests that have been done, they are not sustained, and therefore the problem goes back. And then a basic, a gold standard blood culture, for example, to confirm bacteremia is not commonly done. It is estimated around 25% of blood cultures are being done around Africa to confirm sepsis. I remember on the previous talk that was organized by NEST, there was a talk about the culture of doing culture. Most of the babies are getting antibiotics without culture. And then, for example, expecting early onset sepsis, you want to know, am I dealing with a meningitis or not? And to confirm that one, you need to do an LP. And this is now becoming a rare species. Urinalysis, it's even fewer. Sometimes I think microbiologists are forgetting that you can do urinalysis for babies. Biomarkers like a CRP, which at least can guide us like a duration of a treatment. It's only done in tertiary facilities. Again, we don't have standard protocols of doing it, and then it's become like in fewer facilities, but not in like in a district or regional facilities. It's only in tertiary care. Next. So what are the causative organisms? The organisms are the same. Like if you go to any standard textbook, if you review these papers for early onset, in Africa we see Staph aureus, sometimes you see GBS, but we don't know, do we have invasive serotypes or not? Our babies, we have a very high perinatal mortality, and sepsis being one of them. So we really don't know, do we have invasive serotypes or not? We have cones. I know in the Western world, if somebody isolates cones, they might, it's probably a contaminant, but not in this part. Congenital syphilis is being reported in other places because of poor access to healthcare services, especially for the management of STIs. And then for late onset or hospital-acquired infection, gram-negative are mainly common, though you can get a late onset GBS. And then the bad thing is these bugs are now resistant to the recommended antibiotics. I remember we were reviewing back at home, we were reviewing our antibiogram, and we are seeing cones that are actually mesicillin-resistant Staphylococcus, MRSA. And it was like, okay, so it's not only cones that we think as a contaminant, but now it's even become resistant. And you do a blood culture, you find cones, and the baby is actually really static and sick. And so this is the pattern that we are going. And we are seeing, like, should I call them fancy bugs, which are resistant to our recommended antibiotic protocol, and then we end up being stuck. And this table was again borrowed from a colleague, a systematic review that was done in Africa. They had quite an extensive one just to compare the organisms that are causing bacteremia, meningitis. I truly encourage the audience if they can go and look on this paper. Next slide. So, as I've said, we are now seeing an increasing resistance pattern. If you go just research on the neonatal sepsis. We are seeing ESBL, we are seeing MRSA, and the papers are just a number. I just decided to pick one from a colleague in Tanzania, and another one that just did an extended review, a systematic review for ESBL in Africa. And the prevalence is around 6 to 10. But as I've said, these are basically like a single site. We have seen the number of centers where these studies are being done. We have an issue of detecting, for example, outbreak in our NICU. Most of our facilities do not have surveillance. We don't have isolation. Our NICU are overcrowded. Because of limited resources, we recycle consumables, things like oxygen nasal prongs, the circuits for the ventilators and CPAP. And these are the major culprits for transmitting this resistant bug to the next baby. Sometimes babies share cots, and if you have an ESBL baby on one side and non-ESBL baby, make sure you can be definite by the end of the week or a few days, the other baby will also get the bug. Next slide, please. So in summary, what do we know about neonatal sepsis? We have sick babies, suspected sepsis, who do not routinely undergo microbiologic tests. Blood culture, which is a gold standard for bacteremia, is taken for around 25%. And even if the sample is taken, sometimes we don't use the results. And if you want to confirm meningitis, very few places are doing lumbar puncture. We are talking about GBS. I did not touch the literature on this one, but the prevalence of GBS, this is an area that I also have an interest on. In Africa is around 16 to 24%, but we don't know the type, if we have invasive serotypes or not. And that also imposes limitations as far as our management is concerned. Maternal colonization with E. coli and Klebsiella has been shown in maternal studies, neonatal sepsis, in maternal sepsis, and this can be the cause of early onset sepsis. While our colleagues are talking about gram-positive sepsis, we can see E. coli and Klebsiella because moms get UTI, they are not properly treated because they are not investigated, and they have chorioamnionitis, and they will deliver a baby that is already exposed to E. coli and Klebsiella. And then we have a high prevalence of resistant organisms, which is, I think, is alarming in most of African places, and similar findings are being seen in Asia. One major limitation that we have is we don't do a viral panel, and that is why maybe can explain why we tend to overtreat with antibiotics. Because in a very sick baby that, for example, you've done a blood culture, and then the blood culture is negative, and then your biomarkers are in a borderline, and you're like, this baby is really sick. What do? Do I stop the antibiotic? Am I dealing with viral infection? Your hands are tied, you don't know. Looking at the baby, you are scared to stop your antibiotics, and we really don't know. Maybe in places like South Africa, I don't know about Kenya and Nigeria, they can do a little bit of a viral panel. Back in Tanzania, where I'm from, we really don't know. And that could be the reason we tend to overtreat sepsis with antibiotics, while we know some of them could be viral pneumonia. Next slide, please. So what can we do? I would say supportive interventions. We cannot tackle it with one hand. So we need a thorough assessment, investigation, and targeted investigations. Next slide, please. So the WHO came with infection prevention control minimal package, and they are talking about hand washing hygiene practices. If there was one thing that I would sing to my unit, and I would wish our colleagues in this audience to go back with, wash your hands, wash your hands, wash your hands, because we, the healthcare workers, are the main, we do a good job of treating the babies, but also making them share the the resistant plug for between one baby from the other. And these are from a non-clinical touch. You are touching a file without washing your hands, you are leaving the ESBL there. You are reading a baby's name without touching the hands. You are moving the baby slightly so that you can put another baby. That's it. You are changing the drip, you haven't washed your hands. We have an issue of opening the vials, like for example, IV fluids, and then the baby needs 100 mils, we have 500 mils. We don't throw it away because we want to save, and we leave it open. Studies have shown open bottles, including vials for antibiotics, are highly colonized with organisms. We delay breastfeeding. Yes, sometimes baby can become a little bit sick, will not be able to tolerate maximum feeds. And what do? We are so scared. I'm truly a baby-friendly, breastfeeding-friendly neonatologist, but we are scared of giving these babies formula, and instead we give them IV fluids. So we tend to give them IV fluids instead of formulas if the baby can tolerate, and we don't do KNC as well. Next slide. So antibiotic stewardship programs, this would talk about using of local guidelines, improve diagnostic criteria. Like in level 1 care, we can have a clinical algorithms, but from level 2 to level 3, we should have a proper functioning lab and appropriate tests being done, and antimicrobial surveillance so that we can know what type of bugs we have and the resistance path that we are facing. And of course, we need to have innovative point of care because of our limited in our lab services. So I'd like to conclude my presentation here. Then the other speakers are going to speak more on neonatal sepsis. What I wish to challenge everyone is, like, we can make a change in our own place. Things like hand washing, follow our own guidelines. We can do something to reduce the mortality and the burden of neonatal sepsis. Thank you.
Thank you so much, Dr. Mkony. I'm just passing over to Dr. Michelle Niescierenko.
Good afternoon and good morning, everybody. And so I'm going to talk about some work that our team did on a meta-analysis and systematic review using biomarkers to detect neonatal sepsis. Next slide. And so, as my colleague just laid out, blood cultures have increasing availability. They're present in some facilities, but the majority of facilities in low middle income countries still struggle to have access due to cost and supply chain, facility infrastructure, or skilled personnel to diagnose sepsis by gold standard of blood culture. Next slide. And then we also have the complicated humanitarian settings. And so this map shows the current active WHO designated health humanitarian crises. These are populations that are often on the move, and we have no ability to follow up blood cultures if they were done. And we have limited infrastructure or temporary infrastructure where we can't obtain a culture. And so the default is often to treat with antibiotics. On the next slide, the consequences of not having access to this testing has lots of downstream effects. So we have misdiagnoses, mortality, and the spread of infection, as Dr. Mkony just described. We also have the antibiotic overuse and the antimicrobial resistance. Next slide. And so how can we create a solution to this? One is testing at the point of service when patients are accessing care. And so one way to address this would be using biomarkers or objective physiologic markers in the bloodstream. We have the ability to then measure objectively for infection, yes or no. We can potentially risk stratify patients to see who might need antibiotic treatment and who could wait. These biomarkers have been integrated into many high-income country diagnostic and treatment guidelines. And so our goal was the for low and middle income countries, and specifically procalcitonin. Next slide. And so our research question was, how do biomarkers perform against the gold standard, either blood culture or the physiologic definition of neonatal sepsis for diagnoses in a low middle income country setting? Question on the next slide. We set out to do a systematic review. And so we searched global databases, Medline, Embase, DARE, CINAHL, Babelmesh. We had reviewers on our team that could speak Arabic, Dutch, English, French, German, and Spanish. And so as we extracted articles, we screened them with 2 reviewers each for inclusion or exclusion. And once we included the articles based on abstract, the articles were read and a standardized data extraction was performed. And we built, if anybody spent time in public health or in biostatistics, we built 2x2 tables of the raw data, which is an example of a 2x2 table on the screen, and summarized the raw data into one meta-analysis. And we used, to mitigate the bias of these studies based on the quality of them, a standardized bias tool to grade the studies and weight them. And on the next slide, we'll show you the summary of existing data. And so when we did the search, 6,570 articles turned up. We screened them, as I mentioned, by the 2 reviewers to make sure there were no duplicates and to make sure that it was actually children and the biomarkers of interest. And that led us to review 1,816 articles. We also reviewed the citations in those articles and identify any articles we might have missed in our search and added them. So we added 52 more articles. And when we screened those for inclusion, we excluded 1,734 of them because they weren't about neonatal sepsis. The full paper wasn't available anywhere. The reports or the values for the biomarkers wasn't there. They didn't use gold standard. It was not one of our available languages. It wasn't children. And as you can see down the exclusion list. And so at the end of our exclusion and review, 134 articles were included in the meta-analysis and systematic review. Next slide. So the demographics of these articles, and we screened not just low and middle income country, but high income country as well. And we divided them, as you'll see in the results. And so 80 of the articles were done in low and middle income countries. 91% of them, 0.8, used blood culture as the gold standard diagnostic, which was really encouraging. And then when we looked at each biomarker, the largest number of studies included CRP, 109, or a total of 31,622 patients included in our review. Procalcitonin was next with 31 studies, or 14,847 patients. And then WBCs, or white blood cells, and ESR. And on the next slide, to do a quick review to understand the results, we use the receiver operator curve, which is a binary test for things that have a yes or a no answer. And so what we needed to do in order to make these lab tests, which have a continuous set of results, so you could have a white blood cell anywhere from 1,000 to 30,000, was to transform the variables into a binary yes or no, positive or negative result, which means we had to set a cut point or a threshold for each of the biomarkers. When using the receiver operator curve, we're essentially assessing the diagnostic capability of the test. And so our test statistic ranges from -1 to +1. +1 is the best predictor possible. It's right 100% of the time. -1 is the worst. And 0.5 is like flipping a coin, 50% good, 50% bad, and 0 is no difference. And so our area under the curve, or AUC summary, gives us this measure of prediction. And so when we looked at these biomarkers on the next slide, we wanted to see how they performed. And so first looking at CRP, we found that it did actually have some discriminatory value, meaning it could give us an answer, yes or no. When we grouped all the low together, piece. And there which was a good income, and able to at the low middle income procalcitonin greater than or equal to 2 had a 0.79 AOC predictor. When we pooled all studies, the procalcitonin at a threshold of 1.7 had an AOC of 0.79, so no difference compared to our low middle country studies. And then white blood cell count had very poor discriminatory value. It had poor sensitivity and poor specificity. We couldn't actually even get an area under the curve, and not enough data to analyze. And so on the next slide, these results, when looking at them, we think to ourselves, what's next for the real world? We found good discriminatory value for procalcitonin and CRP, but it's not ready for immediate use. It's not ready to go right to our practices in our countries. We need to look at how these point of care rapid diagnostics or laboratory-based CRP and procalcitonin, either alone or combined against the gold standard of culture, are likely to predict neonatal sepsis in a prospective way to, again, eliminate as much bias as possible. We also have to think about how factors like history and physical exam may also increase their diagnostic specificity, because most guidelines for high-income countries that incorporate these biomarkers also include history and physical exam risk factors, for example, chorioamnionitis, neonatal fever, and the like. And so when we think about where this needs to go, is we need future studies that are designed and prospective to weigh these biomarkers against that gold standard. Next slide. And so our team was really excited to complete this deep data review, and we're happy to take any questions or be contacted by anybody who might have interest. And I will turn it over to the next speaker.
Thank you so much, Dr. Niescierenko. I would love to pass over to Dr. Cecilia Ferreyra from FIND.
Thank you very much, Mita, for your kind introduction, and good morning, good afternoon, good evening to the participants. It's a pleasure to be here to talk a bit about the landscape on the diagnostics for neonatal sepsis. So if we go to the next slide, I'm going to be walking you through a recent technology landscape that has been done by FIND in the last few months. Next, please. And I think by hearing the previous two presenters, when we talk about diagnostics for neonatal sepsis, it's a dream. So I think always at FIND, when we talk about diagnostics for neonatal sepsis, we use this sentence: as you move towards the dreams move closer to you. And I encourage all of you to keep dreaming, to make sure that we can have soon pretty easy to use diagnostics for neonates. Next. So as it has been described already by some of our colleagues, we have different diagnostic technologies that can be used at different points of the babies. And the neonatologists that are presenting today, but also attending this webinar, they know how challenging it is, not only in terms of having access to these diagnostics, but also understanding when to use it. We all know it's not the same a CRP in an early onset neonatal sepsis that on a late onset neonatal sepsis. So there are a lot of also research gaps there that need to be answered. Next. So we'll start a bit with the biomarkers and the point of care hematology platforms that this could be used for triage of severe babies and can also be used to guide antibiotic treatment. Next. So some of these platforms can be used for sepsis biomarkers detection, but can also be used for what we call viral versus bacterial, which basically is giving us indications on whether to start an antibiotic treatment or not, or to stop antibiotic treatments. That sometimes at a hospital level, we want a baby to be discharged home So the sooner we can stop the antibiotics in a safely manner, the better. So there are a number of technologies out there, as you can see, smaller, friendly. Some of them are multiplexing. Some of them have higher multiplexing capacity, which means that you can use it for several conditions. The time around results is pretty fast for most of them. However, price is an issue, as we all know. Some of them are not yet available, like the Inflamatrix is under development and the Cytobal as well. The others can be used also, they do have panels, for example, for CRP, for procalcitonin, and for other biomarkers. Some of them have already got an FDA clearance or approved. But what is particularly interesting from some of these technologies is that they cannot be sitting in a place without an air conditioning, which is one of the limitations that our colleague Martha presented earlier before. Next. So some of these technologies are already proved to have very good results, particularly detecting bacterial versus viral infections. None of them has been studied in an LMIC, and most of them have been, the clinical studies are coming from high income country settings. There is one technology particularly interesting from our end, which is the one on the right side, my right side, which is the BodyTech. Is the only one that is having EL6, CRP, and procalcitonin together in the same technology, and use a very low volume of blood that, as we all know, also to get blood from these babies is really an issue. It can be used with a heel stick. It's being commercialized under CE and IVD, but still the price remains quite high. And as I mentioned, it hasn't been evaluated in an LMIC setting. Next. When it comes to point of care hematology and the triage of patients, as we all know, it hasn't been proved to have a good sensitivity and specificity, but still white blood cells are being used for babies in most of these settings. And if you ask one clinician or neonatologist, will you get rid of white blood cells? Very few of them will say yes or no. So we are still exploring point of care hematologies that could be used at a very low level of care. It could be sitting at admission in an NICU, for example. What we have been looking also within these platforms is that they can be robust enough for high temperatures, for dusty environments, and to be used when there are power outages. So we are looking really for a very robust technology. So currently, FIND is supporting the first one you see on the left that is being called Biosurfeit. It has 5 teeth counting. Other assays that can be used are CRP, HbA1c, and lipids. They're also working on a procalcitonin. It's going to be on the market soon. The price is still high for white blood cells, but when you think that it can be used at the side bed of the patient, it really makes it more interesting, especially because it can also run other biomarkers like CRP or procalcitonin. Next. Then it comes the next step, right? Because with our CRPs or procalcitonins or biomarkers, we have already decided the baby has a neonatal sepsis, and we would like to do a blood culture system next. And we know that this is one of the most challenging parts. Very few laboratories in LMICs, particularly in Sub-Saharan Africa, have access to microbiology. There has been very few investments on making sure that hospitals have access to microbiology. The Fleming Fund has done an amazing job on bringing microbiology services closer, but still there is a long way to go. And when you look at all these technologies, they are all too big, too expensive, too complex to be used in those settings. But if you start looking a bit more outside what is already available, you find other technologies, particularly in the Chinese market. They have been working a lot on this area. FIND has been supporting the company that is down on the right, Outbio. They are already on the market. They have already been used mostly in Latin America and Southeast Asia. The technology is pretty much the same, but it's smaller, cheaper, more robust for high temperatures and dusty environments. The work we are doing with them to make the technology more robust is finished, is middleway finished. We are about to do a field evaluation of the platforms that we develop with them, and hoping they can make it through regulatory approvals and be in the market by 2024. Next. And then it comes the identification and susceptibility profile. Next. And we know that it's not only about having a blood culture positive, but then you need quickly to get a result on what is the bacteria that I'm treating, and is the bacteria sensitive or resistant to the antibiotics that I'm using. So there are a number of molecular platforms out on the market. Some of you might be familiar with some of them, BioFire, Denmark. All of them are fully integrated systems, PCR systems with big panels. Most of them are having gram-positive, gram-negatives, but the price remains extremely high. They are quite sensitive also for high temperatures or dusty environments, and sometimes it tends to be quite complicated as well. Next, to understand the results. And then there are other smaller platforms that, thanks to COVID, some positive things happened after the pandemic. There were a lot of point-of-care, molecular point-of-care that were developed that now we are trying to leverage through after COVID to see what else can be done with those. So there are these two, Bioneer and Optin, that FINDx is supporting. Both of them have very high multiplex capacity. And again, we are looking for a robust technology with a lower price than what is already available, and that can be sitting in a level 2 district hospital in an LMIC. Next. And last but not least is dream. We keep dreaming that we can have a bacterial identification from blood. So if we go to the next slide, I just wanted to show you that there are some technologies out there. Some of them are in development. The T2 biosystem is already commercially available in the US. Is the size of this room. So it's a really big technology, which still takes 3 to 5 hours. But the price remains prohibitive even for high-income countries. There are a number of other technologies that are on the way. Most of them early technology development, but I think this is still a light at the end of the tunnel. I think we all would like to see this kind of technologies, particularly for babies. Having the blood samples being a problem, the volume, the contamination rates. So if we could have something that directly from blood can give us a result for the baby, that will be the dream. Next. Babies is another solution that we are following up pretty close. It's still under development. It's an integrated solution for both, from blood culture to IV and AMR, so it does everything in one way. It's a near patient instrument design as well. It requires a minimal volume. It can do the blood culture, the PCR, and the digital microfluidics for the pathogen ID and AST profile, but it's still in early development. But we are following up, looking forward that this can be a real platform in the next few years. Next. And I wanted just to close this session by sharing with you what is next in terms of diagnostics for neonatal sepsis. As some of you may know, we have been working with the NIES360 group, and we co-organized an expert meeting last year in November, which was really an exciting meeting with a lot of experts from LMICs to define what are the diagnostic needs, urgent diagnostic needs. Since then, we are working on a target product profile that is still under work and will be publicly available for feedback from the public community in the next few months. And the final result after this TPP will be to open a request for proposal, looking for companies and manufacturers that will be willing to develop a test that can be a low price to work with low volume and have a result in few hours or shorten the current workflow that we have with babies. And with this, I'm finishing my presentation, open for questions, and over to you, Mita.
Thank you so much, Dr. Ferreyra. Our next portion of the event will be a Q&A discussion with panelists, and I'll hand over to Dr. Kara Palamountain.
Hi, thank you so much. So we do have a chat open, so please send your questions through the chat. We have one question that's come in. Can you describe what you mean by high, medium, and low cost? And I think this pertains to potentially the commercially available or pipeline technologies that you mentioned. Even ballpark would be helpful.
Sorry, Kara. So I think the high, medium, and low cost, I don't know exactly what the question means. Just to give you a rough example, a malaria RDT in an LMIC, the price is $1. When you go to a blood culture, in some places the patient have to pay because it's not going to be for free. A blood culture may be around $10. And just to give you an example of a nurse salary in Zimbabwe is $100. So I think it's from there you estimate that whatever the price of a molecular point of if it is a molecular point of care, cannot be at $350 as it is today. So the lower the price that the patients can pay. There are a lot of TPPs that are also estimating, and we are working also doing some modeling studies to see what will be the right value, but it has to be a price that both patients and Ministry of Health can afford.
Great, thank you. We have our next question. What does the panel think progress in the field is? Why do you think the progress in the field is so slow, despite the escalating emergency?
I think we might have lost Kara, but to the panel, I think the last question was, why do the panel think progress in this field is so slow, despite the escalating emergency of AMR? If Martha or Michelle would like to go ahead.
I'm happy to contribute from the diagnostic perspective. You know, the development of diagnostic tests is clearly making great progress. One of the biggest challenges is we need to validate these diagnostics against the gold standard, which is culture. And there's so limited facilities with culture, and the cost of doing a prospective trial is quite prohibitive. And I think the investing in this level of research and the capacity that it takes, you know, Dr. Martha and her colleagues at Muhimbili run a phenomenal research outfit there. And so taking hospitals like Muhimbili and investing in the research where there's gold standard available would really advance the use of these rapid diagnostics. You know, with malaria, you can do a quick microscope smear, which is relatively low cost, but there's no quick blood culture, as you know, as our colleagues have talked about. And so the challenge is really being able to validate them, given that the risk of an untreated neonate is catastrophic.
Great, I apologize for dropping off. I am in a rural site with limited internet, so I apologize for that. We have another question asking for any optimism around host response diagnostics as differential thresholds and potential complexity in babies, especially the preterm. And if there is any hope, what's the best hope?
I can jump in. In the meantime, I think the biomarkers is a great sum that we haven't been able to answer all the research questions that the neonatal community has. As we saw from our colleague before, CRP seems to play a role, but then when you look into details, in particular timelines, when you take the CRP values from the baby, the importance is not that high, right? And we just finishing a literature review, a huge literature review on the role of biomarkers on early and late neonatal sepsis. And what we see is a full heterogeneity of the research. There are not many studies looking in an organized manner to biomarkers. And I think that's what we need from the research community. We need a bit more data using different biomarkers at different time frames and for different use cases. We need studies on biomarkers to define whether a baby has a neonatal sepsis as a diagnosis, but we also need to see how biomarkers perform to stop antibiotics and de-escalate antibiotics. And I don't think the literature is yet there.
We have a couple more questions. A question for Dr. Niescierenko. Is there information available in the included studies around when the biomarker samples were collected? For example, at the onset of symptoms or mid-illness? And I just want to add on to that, potentially at the community level or at a hospital setting.
Great question. We limited this study to the initial evaluation for someone's concern of sepsis. So it was done at whatever point the clinical team were trying to determine sepsis, no sepsis, and initiate antibiotics. We didn't do any prolonged biomarker monitoring or late course testing to determine to take antibiotics away. Those would all be areas that need further studies to identify what thresholds, might these biomarkers be used. Included preterm infants in this study as well, just given the complexity of host response in premature infants versus full-term infants. And so similarly, a study would need to be done in different ages of prematurity to assess biomarker utility there as well.
Great. And then I think maybe this is the final question, James. There's some interest in this Bioneer multiplex. So the name of the product, expected time on the market, when can we get it, available of ID panels and cost?
Great. So as I mentioned, we are working with these two companies, Bioneer and Opgene or Curetis. We are advancing a bit farther and faster with the Opgene technology. We have just finished the development of the panel. And the trick on the price is that the smaller your panel, the cheaper it becomes. So if you have 30 pathogens in your panel, that will be a very expensive panel. So we are working on a very simplified panel that is covering around 10 pathogens coming from the WHO priority pathogen list, but also for some of the data that has been presented by Martha before on what are the main pathogens in neonatal sepsis in LMICs, plus resistance profile. If everything goes well and funding becomes available to continue supporting this development, the technology might be out there by end of 2024, although we are going to be working on some preliminary clinical studies by the end of this year.
Great. Thank you so much to all of our panelists for taking those questions from our audience, and thanks to our audience for those terrific questions. James, I will hand it off to you.
Okay, thanks so much. So to close, it's been a really great seminar and some really insightful discussion. I think the thing I was just reflecting on there a little bit was how I think we've been talking about this in a previous seminar as well, about how we have to break down those silos of thinking, so to speak. And how maybe bringing more finance, more economic, more logistical experts into this fight would be a good step forward. And it's good to see, I can see some economic based people on the call today. So that's great. So just really appreciate the speakers to push us to keep dreaming for this new diagnostic test, not to give up the fight. But at the same time, we also heard how we need to sort of take action today and really keep pushing the prevention of these infections in the first place within the wards that we work in. So I just want to say a big thank you to all the participants and the speakers for today. I hope you've enjoyed this Nest 360 UNICEF Newborn Toolkit HSBB seminar. And if you have any further questions or comments, please feel free to contact the team. We'd like to encourage you to visit and contribute to the toolkit and sign up to the newsletter on the links, as you can see here, where you'll also be able to see other seminars that are advertised in the coming weeks and months ahead. We look forward to meeting you all again, and as we sort of continue to learn together for the benefit of every newborn. So thanks very much, everybody.